Hi, I'm Tan Hein from Hematology Department of Singapore General Hospital, and I'll be talking about microcytic anemia. Anemia is defined as decrease in hemoglobin level below the standard range for the age and sex of the individual. Anemia can be classified in many ways. One of the most useful and practical ways is the classification according to red cell indices. Based on mean cell volume, MCV, it can be divided into microcytic, macrocytic, or normocytic anemia. Common causes of microcytic anemia are iron deficiency, thalassemia, and hemoglobinopathies. Others including sideroblastic anemia, lead toxicity, or copper deficiency. In daily clinical practice, almost always the first step to consider is to differentiate between iron deficiency and thalassemia when microcytic anemia is encountered. Iron studies are important for that. In iron deficiency, serum iron is low, total iron binding capacity is high, hence transferrin saturation is low, and ferritin is low, except in associated infections or inflammation. Whereas in thalassemia, serum iron is high, total iron binding capacity is low, and ferritin is moderately to severely high due to iron overloading. However, in thalassemia trait, iron studies may be normal. Menza index, which is the ratio of MCV over red blood cell counts, can also be used as rough estimate to differentiate between iron deficiency and thalassemia. The index of greater than 13 suggests iron deficiency, and that of less than 13 favors thalassemia. Further tests that can be used to investigate iron deficiency include soluble transferrin receptor and bone marrow iron staining, which is not routinely done to diagnose iron deficiency. Therapeutic trial of iron replacement may help with diagnosing iron deficiency in otherwise healthy patients, for example, in pregnancies and premenopausal women. To manage iron deficiency, iron replacement is as important as finding out and treating the cause of iron deficiency, which is usually bleeding. Upper and lower GI endoscopic evaluation is indicated in adult men and all postmenopausal women. Among premenopausal women, GI investigation is recommended for women over 50 years old, those with GI signs and symptoms, those with strong family history of gastric or colonic cancer, and persistent anemia despite appropriate iron replacement. Iron can be replaced orally or parenterally. Side effects of oral iron replacement include nausea, epigastric discomfort, and constipation. Iron can be replaced parenterally if there is malabsorption, intolerance, or non-compliance to oral iron. Parenteral iron can cause anaphylaxis. Coming back to workup for thalassemia, hemoglobin electrophoresis is done for beta thalassemia. Hemoglobin H inclusion bodies can be found in alpha thalassemia and hemoglobin H disease. Gene analysis is often required for diagnosis of alpha thalassemia. Management of thalassemia is multidisciplinary, including regular blood transfusion, iron chelation, and treatment of target organ damage from iron overload, which involves hematologists, pediatricians, cardiologists, and endocrinologists.